Hi, my name is Anam Faisal. I am a third-year medical student at the University of North Texas Health Science Center in Fort Worth, Texas. Today I'm going to be talking to you about a case of treatment-resistant catamenial disease, insufficiency, and mainstay treatment options. This case study was done at Houston Methodist Hospital. Thoracic endometriosis syndrome, or TES, is a rare phenomenon that affects 6 to 10% of women of reproductive age. It's characterized by the presence of ectopic endometrial tissue within the thoracic cavity, mainly the lung parenchyma and pleura. TES presents as catamenial pneumothoraces, catamenial hemothoraces, pulmonary nodules, or hemoptysis. Hormonal therapy is considered first-line treatment, followed by operative thoracoscopy for removal of ectopic endometrial implants. Our case today highlights the limited number of treatment options in a young patient with recurrent catamenial disease. Our patient is a 37-year-old G4P0040 female who presented to the emergency department with worsening shortness of breath for 5 days. Her shortness of breath was sudden in onset, progressively worsening, associated with cough and right-sided chest pain localized to the lateral right mid-lower rib cage. She was admitted 5 months ago for similar symptoms, where she underwent a right lobectomy due to pleural effusion caused by her TES. She has a past medical history significant for hypertension, obesity, iron deficiency anemia, severe endometriosis, and TES manifesting as recurrent right-sided pleural effusions, catamenial pneumothoraces, and catamenial hemothoraces requiring surgical treatment. Her current medications include leuprolide, 11.25 milligrams of injection every 30 days, norethindrone, and ferrous sulfate daily. Previous biopsies of the ectopic endometrial tissue revealed dense fibroconnective tissue consistent with focal endometriosis and no indication for malignancy. In the ED, she appeared in distress and had a blood pressure of 166/102. Physical examination revealed tachypnea, accessory muscle usage, respiratory distress, and retractions. Her breath sounds were decreased in the right lung. EKG revealed normal sinus rhythm, and a COVID-19 test was administered, yielding negative results. A chest x-ray and CT were ordered, and if you look at figure 2, where we see the chest x-ray, we notice this increased large right pleural effusion and right lung volume loss. The left lung remains relatively clear. Her coronal chest CT, over here in figure 1, shows again a large right effusion noted with multiple loculated components. There's very little aerated lung seen on this side, consistent with compressive atelectasis, and again, the left lung is relatively free of infiltrate with normal lung markings here and no evidence of PE. These two imaging studies were consistent with findings for right tension hemothorax. She was started on BiPAP initially, and thoracic surgery was consulted. A tube thoracostomy was performed in the ED and a chest tube was placed. The patient tolerated the procedure well with no immediate complications. Her CBC revealed a hemoglobin level of 5.7. She was then transfused 4 units of pure RBCs and admitted to the ICU for further monitoring. An OB-GYN was consulted and leuprolide was administered to prevent recurrence of a hemothorax. She remained in the hospital for 3 days and was subsequently discharged after resolution of symptoms confirmed by imaging. In conclusion, catamenial hemothoraces are a late finding of TES. In our literature review, we found mixed data regarding the effectiveness of GnRH agonists such as leuprolide on the recurrence rates of catamenial hemothoraces. However, subsequent surgery was shown to be preventative in those resistant cases. Our unique case today illustrates the insufficiency in both mainstay treatments. Despite the fact the patient had previous lobectomies using VATS, lysis of adhesions, and hormonal therapy, she continued to have recurrent manifestations of TES. Novel treatments and a multidisciplinary team approach should be used in conjunction to effectively treat TES and prevent disease relapse. Thank you for your time.